at Caroline's Healthcare, it was 2008. At that point, there might have been 10 urgent cares, a part of Caroline's healthcare system in the whole city. We now have like 32.
Hi, everyone. It's Rodalyn. Hi, and we have Wesley today. Wesley is an urgent care PA. Thank you, Wesley, so much for coming on.
No problem.
Thank you. Wesley, of course, we're going to find out about his PA career, how he got to becoming a PA, and then get some insight on the urgent care life, and of course, go over the case studies, which I'm so excited for, and then answer questions. So we're going to first start off. Wesley has been a PA for over 17 years, based on what the research I've done, and he's done nephrology in the past, I saw, and now he's in urgent care for coming on. But how did you first get to becoming a PA, since it's a relatively new profession, especially when you started?
I actually, I didn't even know about it until like my junior year in high school. Somebody told me about it. I forgot who it was, but I was like, yeah, that seems like something I could do. Like I could really see myself being a PA, just practicing medicine, but yet not, having, necessarily not trying to be a doctor. And I looked at the pros and cons of doing both, going to med school to be a doctor, going to be a PA. And I was like, you know what, being a PA, I have room to pick different specialties. I can move to different specialties if I want to. I'm not like beholden to one specialty. Of course, less time is a benefit as well. And I was like, I think this is a good idea. So when I went to college, I attended South Carolina State University, and I knew from my senior year in high school, I wanted to be a PA, and I went about the process to do it. Now, when I went through school, it was a little bit different. You could actually become a PA with a BS degree. So all you needed to get was prerequisites. I forgot what the requirements were, but it took me 3 years to meet them instead of 2. But I got all the prerequisites. I applied to about 5 or 6 different schools. I got 3 or 4 rejection letters and 2 people accepted me. One was MUSC in Charleston, because I'm from South Carolina. They tend to pick local a lot. And then the other one was Des Moines University in Des Moines, Iowa. And I wound up going to Des Moines University in 2001, and I graduated in 2003.
Oh, wow. So how was it when you graduated? What was your first specialty, or what did you first get into?
I worked in a community health center, Regenesis Community Health Center. They only had 1 clinic when I started in 2003. I didn't stay there too long. Me and management had a little bit of an issue. And she was a South Carolina State graduate. I really liked her, but it was just, we were trying to get some things together, and we was having some issues with the supervising physician. So I was like, you know what? It'd be a little bit easier if I just went ahead and cut my losses. So I wound up leaving that place. And then I wound up working in nephrology back in my hometown. So that I like to consider, granted, I worked at a community health center, but I didn't stay there long. I like to consider my job at a nephrology as my first real job, because I stayed there for a year, and I got a lot of internal medicine experience. And then I transitioned over to primary care at that point.
So you said you went to nephrology afterwards?
Yes, I did nephrology.
Okay, wow. What made you do nephrology? Because I feel like that's such a hard specialty, especially to just, I guess, learn. And it's, of course, highly specialized. What made you get into nephrology? Was it just like the opportunity, or did you have an interest in that?
All right. So it was 2 things. One was opportunity and one was interest. From the opportunity standpoint, the story behind it, my mom actually got me that job. I wound up doing I did one of my rotations back in my hometown, and I worked with a doctor named Dr. Smoke. And that was actually my mom's primary care doctor. So I worked with him doing family medicine for a while. So I had just left Regenesis, and I was home, and my mom had a physical. And she said, she was talking to Dr. Smoke, and Dr. Smoke asked about him. She's like, "How's Wesley doing? I haven't heard from him in a while." She said, "Oh, well, he had some issues at his last job, and he was looking for another one." He was like, "Well, I do know a nephrologist that's looking for a PA, so you can actually tell him about it." So she gets out of her physical. She drives home. She says, "You need to call Dr. Mustafa." And I'm like, "Who's Dr. Mustafa?" And she was like, he's a nephrologist who's looking for a PA. And she gave me a number and everything. And I called him. And he basically told me everything that I would be doing. And I liked it. I do enjoy internal medicine, primary care. That's kind of like my thing. I always wanted to do primary care when I graduated. And I knew that there's certain specialties, especially in a small town. Like, you have to understand that the small town that I'm from, the cardiologist there had like a primary care office. So he had like an internal medicine office. So my town was real small. And Dr. Smoke, who I did my rotation with, he did his own colonoscopies. Like, that's how small my town was back in 2003. So I knew that Dr. Mustafa, although he didn't have primary care patients, I took care of a lot of people from a primary care standpoint too, because they would talk to him about their problems when I'm rounding in the dialysis clinic. And, you know, he would do some things to try to help out as much as he could, you know, granted, because nephrology is a very busy practice, especially in a small town that's very prevalent with a lot of things that causes patients to be on dialysis: high blood pressure, diabetes, moonshine. Like, it's a whole lot of stuff, because lead can actually lead to renal dialysis as well. So for that to be so prevalent, even though we were so busy, he still had some patients where he treated as a primary care person. Plus, I got a lot of experience because he actually did rounds at the hospital too. Now, 17 years from what y'all are going to be dealing with now is y'all going to be a lot more specialized if you go to a major city. They're going to be nephrologists who strictly do hospital work. They're going to be nephrologists who strictly do clinic work. They're going to be cardiologists that strictly do hospital work. They're going to be cardiologists that strictly do clinic work. And they're going to be primary care doctors who just do clinic work. And they're going to be hospitalists that are internists that just do hospital work. In 2003, in a small town, we did it all. So I would round in the hospitals in the morning, and then I see clinic in the afternoon. Or I'd round in the hospital in the morning, go to a dialysis clinic, round on those patients, and then see clinic in the afternoon. So it was a lot less specialized, and I got a lot more experience, and I really, really enjoyed it. So, I mean, I know that's a roundabout way to answer it, but it was basically, yes, it was the opportunity, but it's also the fact that I do enjoy this kind of work.
Wow, and that's really great, especially getting started basically as a new grad. And how long did you do nephrology for before you?
Well, no, I actually switched over to primary care. I wound up moving from nephrology.
Oh, primary care.
Yeah, and I'll tell you another story. I went to another small town. Heath Springs is the name of the town, and that town was so small until the pulmonologist there had a primary care clinic. So I wound up leaving nephrology and working with a pulmonologist in his primary care clinic, seeing all the patients. So it was no peds though, nobody below the age of 5, because we didn't do any immunization. They really had to go see a pediatrician up until that point. But I think he started like 13 and up is like internal medicine type stuff. So if you either were the age of 13 and up or you had some sort of comorbid condition, you go to his primary care office. So the pulmonologist rounded in the hospital in the morning, and I saw primary care patients, and then he would come in the afternoon some days. And I stayed there for about 2.5 years.
Okay. Oh, okay. Wow. And so how did you get into urgent care, or where you are now?
Okay. So the process for that was I left Heath Springs and I went to work in Charlotte. I got me because my overall objective was to work in a major city, and I just went the roundabout way. I didn't try to find a job in the city. I worked in small towns for a few years, got my experience up because you can do a lot more. And then once I got 3-4 years under my belt, I applied for primary care jobs in Charlotte. And I got 2 interviews, and I got one that hired me like right on the spot. Like the first person they were thinking about, it was between me and somebody else. But the second person, it was like, no, you're perfect. This is exactly what we need. And they hired me on the spot. Now, I started working for Atrium Health at that time. It was Carolina's healthcare system. Carolina's healthcare system was just starting up their urgent care. Because I'll be honest, when I started in primary care at Carolina's Healthcare, it was 2008. At that point, there might have been 10 urgent cares, a part of Carolina's Healthcare system in the whole city. We now have like 32 in the last 12 years. So urgent care has really shifted. But when I first started, I forgot her name. No, Dr. Allgood, Sarah Allgood. I never forget her. She was trying to get an urgent care around the corner from our job, from our primary care place. And she fought hard to get that urgent care open. So what Tracy, this office manager, me and Tracy did was we actually went over to the urgent care and we talked with Dr. Allgood. It was like, look, if you have patients that come in that don't have a primary care, we're a part of Caroline's healthcare system. You just send them around the corner to us and we'll take over from there. And she also came up with the idea, was like, it would be a good idea if you actually came and worked moonlight hours at urgent care too. That way, if I saw the patients, I can tell them who's the provider that they're going to see. So we can set up a little system where, hey, I don't have a primary care. Well, Wesley's working, you can actually meet him and he can actually set you up an appointment at his clinic. So that's when I started working in urgent care. It was actually like 2010, but it was only part-time. I would, and this was in my 20s. So this is when I actually was working a lot, because you grind in your 20s. That's what you do. So I would work at my full-time from 8 to 5, and then I would go to the urgent care and work from 5 to 8. So, and then in those 3 hours, I would see patients, and if any of them didn't have primary care, I'd give them my card and say, hey, call this number in the morning, tell them that you saw me at urgent care and we'll get you in. So, and that really helped me build my practice over the last 10 years. Plus, I was getting urgent care experience at the time. So that really helped out.
Wow. And it's been now 10 years that you've been basically urgent care since 2000.
I left primary care in 2017 and I went urgent care full time in 2017.
Wow, that's still a long time. It's not 2021. So big ups to you. Okay, so can you tell us a day in the life of an urgent care PA, what you do to patients that you see, procedures that you may perform?
Okay, so I'm going to have to give you COVID and pre-COVID as far as patients that I've seen. Because
that's very true.
Yeah. So
very
as far
true.
as COVID is concerned, all I'm seeing now is that I would say half of the patients that I see are getting tested for COVID because they think that they have. We had to set up guidelines.
Oh, that's like all we see.
Yes.
Wow. Yeah, that's wow. Yeah. No, I was saying I'm in urgent care too right now. And like maybe 90% of the patients are like COVID complaints, or they just want to be tested for COVID. So you're right. So yeah, a pre and post COVID, BC and,
exactly.
and PC.
Yeah. It's BC and DC, before COVID and during COVID. So.
Oh right. Oh yeah, because it's not that right.
Yeah. So DC during COVID is mostly COVID. The patients that I'm not seeing for COVID is not even upper respiratory and sinus stuff. It's the fractures, it's the sprains, it's the motor vehicle accidents. We do a lot of workman's comp at our job, so we see a lot of workman's comp. Occupational medicine. I've done a lot of employee physicals recently because. Well, I did and I stopped. So the story is that our CMS was supposed to be opening back up because the numbers were going down as far as the COVID-related numbers, but then they shot back up after Thanksgiving. So now they've gone back to all virtual. So I'm not doing as many employee physicals. But when they were ramping back up, I was doing quite a few more employee physicals because we have a contract with CMS. So I think that's, workman's comp, the sprains, the fractures, and all that kind of stuff. And half of it was COVID. Now, before COVID, it would still be, flu-like symptoms, but, we'd be running a lot more flu tests than we're doing now because honestly, flu is non-existent. Like we've actually tested a lot of people and most of the stuff is false positives because I don't know if it's because of the social distancing and the wearing the mask, the reason why flu is not being transmitted, or whether or not it is the virus itself that's causing an issue. The fact that COVID transmits faster than influenza. I have no clue what's going on, but we have not seen any flu. I've only seen one positive flu test this entire season. And my colleague, she's seen 2. So we're talking about 3 in a situation where we would have seen a whole lot more than that by now in our clinic. And we're testing. It's not a mandatory test anymore. It's not a first line test. We have to say that we want to do it. But even out of the amount that we do, the percent positive that we're having, Dr. Kayla just sent us a number. Our percent positive is like 1%. So he's advocating for us to stop doing a flu test because he wants to keep because we have the Abbott flu test, which means that we can also do the rapid COVID test. So he's advocating for us to just don't even run the flu test. Just keep them open to run the COVID test because there's no reason, because it's really not prevalent. And even in the emergency rooms, the last numbers that I saw in influenza hospitalizations at all, like everybody who's getting hospitalized right now is strictly just because COVID related stuff. And they do viral cultures in the emergency room. So they test for all viruses. So, well, I shouldn't say all of them, but they test for a lot more than here. And they're still not seeing a lot of flu. So,
yeah.
So that's, oh, go ahead.
No, I saw one student ask if it's could be due to the mask policy, and I feel like that could be a major reason, and it's really helping to also bring down other communicable diseases like the flu, because you're wearing a mask, you're socially distancing, you're practicing proper hygiene. That's going to bring it down. So yeah, that's amazing. Because at my hospital, we never tested for the flu to begin with. We just kind of treat it if we thought it was that.
Yeah. And I'll be honest, we usually do. It wasn't like I forgot what they called it, but there's a word to describe how anybody who comes in with these symptoms, they automatically get swallowed for the flu. So we stopped. We didn't do that this season, and even though we're not even testing, the people that are getting tested are negative. Plus, we haven't seen any real high fevers anyway, because most COVID patients, the temperatures ranging anywhere from 99 to 101. Normally, if you got the flu, your fever's 103, your heart rate's like 130, 140. I haven't seen anybody with any of those symptoms at all. And like I said, I've only had one positive flu test this whole season since everything started. So. And it's I think that the mask thing is true. I think that the social distancing is true. Washing our hands is true. But we'll know for sure next year, because basically everybody's going to stop doing it anyway. So we'll see what happens next season as far as how bad the flu season is actually going to be.
Right.
Oh,
okay.
I'm sorry. I was supposed to talk about what I saw before COVID. Right, so,
yeah.
Before COVID, yes, we saw a lot more flu, bronchitis, and all that kind of stuff. We did quite a few more. Sports physicals, because sports isn't completely gone, but it's definitely decreased. So I saw a lot more sports physicals, a lot more college physicals. We're seeing about the same amount of DOT, because I am DOT certified. So we see the same amount of DOT. Department of Transportation people, they still come through, so that's not an issue. And then it's just typical stuff. They haven't given us an outline of what we normally see, because in family medicine, every month we had a meeting, and they used to tell me the top 5 things I saw for that month. And working in an urban environment, it was always the top 5 things: complete physicals, well child check, hypertension, diabetes, and then depending on the season, it was either allergies or flu. So that was my top 5 thing. In urgent care, they don't give us that number. They basically just give us an outline of what our budget is and what we've been doing. So I couldn't tell you 100% sure what my top 5 things are, but I do know that before COVID, I was doing a lot more sports physicals. I was doing a lot more same amount of DOT, but a lot more employee physicals and things like that. During COVID, my occupational medicine side has gone down. I'm doing a lot more COVID tests, a lot less flu tests, and we're seeing a lot less flu.
Okay. And what about procedures? Because one thing that I noticed when COVID initially started was that I was getting a lot of lacerations. People at home, they have nothing to do. They're doing home improvement stuff and get cuts and lacerations. So are you seeing more procedures as well? Or was that more of a before COVID type thing, or doing more procedures?
Well, no, I just got finished doing I had 3 lacerations on Monday. Not Monday. Last on Sunday, I worked Sunday. So yeah, I'm seeing a lot more lacerations now. In fact, it was 2 on the hand and 1 on the leg Sunday, and then that Friday I had like 2 hands. And yeah, people got to cook and they can't. So of course you're gonna see a lot more people cutting themselves. So that makes sense. For some reason I've done a lot more foreign bodies, either nose, eyes, or ears. I do steroid injections, knees, shoulders, hips, and trigger finger. So I've been doing quite a few more knee injections for like workman's comp people who have this persistent pain, a few more shoulders. I actually did a shoulder injection on my front desk lady. So, cause she didn't want to quote unquote go nowhere else. So yeah, I do injections. I've done a lot more laceration repairs, and I've done a lot more foreign body removals. That's about it.
Okay. So I have 2 more questions for you. The first is, can you tell us about your hours? How are the hours like in urgent care, or the days that you work?
I'm gonna explain my schedule, and it's gonna be a little confusing, but it depends on the type of schedule you have. I am on what they call a 3-3 schedule, where I technically work 3 days a week. If you add up all the shifts over a 4-week period, it's 12 shifts, but it's really 3-3-4-2. So here's the schedule. I work Monday, Tuesday, and I'm off on Wednesdays and Thursdays. The next week, I'm off Monday, Tuesday, and I work the Wednesday and Thursday. I work every 4th Friday, every other Saturday, and every 4th Sunday. That's the schedule. That schedule lines up where I average about 3 days a week. If I want to pick up extra shifts, of course, they are available. I mean, I don't now, but I mean, I used to work a whole lot more than I do now. As I told y'all, that was my grinding period, 20s and 30s and stuff. So, but now I don't do that. I just do my normal schedule. But yeah, so that's my 3-3 schedule. It's 8 o'clock in the morning until 8 o'clock at night. However, urgent cares are different. Some urgent care stop patients at 7:30, so you can get home at 8. Some you have to see them up until if the last one walked in at 7:59, it has to be seen. So we are the latter.
Mine.
So if they walk in at 7:59, they're still to be seen. Now, Novant Health, please stop seeing patients at like 7:30 so they can try to get home at 8. But no, if somebody walks in, you have to see them. And I think that during the pandemic, I've gone home on time in the month of from the end of October, because I took a week off in October. From the end of October until now, I think I've gone home on time probably 3 times.
Wow. So how late do you stay?
Average,
better not be past an hour.
Yeah, I was about to say average is about 8:30, 8:45. The latest I've stayed is 9:45.
Okay. And how many patients would you see in a day? Because I know at urgent care it can get crazy. Like, I think the most I've seen was like 40 patients, and a lot of them were just like COVID testing, so it would be like in and out. But sometimes I know, like, if it's just one person, then you can see like 60 patients in a day in a 12-hour shift.
Yeah, I was by myself on Saturday, and I think it was like 41 or 43. 2 provider sets are a lot better because then you can see 60, 70 people, but it's split up between 2 people, so it's not as bad. The most that I've seen by myself is 48. And when I'm with another provider, I've done like 70 or 80 a couple of times. Our average number for a 2 provider set is about 50. And for 1 provider, it's anywhere between 27 to 35.
Okay, that's good. That's not bad. But it's just when you're alone and seeing, all those patients, especially as a new grad. Yeah. And that's actually what I wanted to get into, like my last question or 2 questions before we go into case studies. Because I know as a new grad, it's hard to get certain jobs. Especially like emergency medicine, urgent care. And I think it's those type of jobs where, you're not going to necessarily be with the doctor, or you're not going to have that doctor there like every step of the way as you would with or coordinate with the doctor as much. So what do you think about new grads and wanting to start off in the in the urgent care? Because I know you're by yourself, right? You don't necessarily work or have a doctor there.
Yeah, no, I'm by myself sometimes, and sometimes I work with somebody. When I did night shift, I worked by myself because we used to have a 24-hour urgent care in Rock Hill called Riverview Medical Center, and I was the night shift guy. So I was by myself for like a year. So I'm different in the sense that I grew up in a sink or swim era. So it was basically my first job, my first real job out of PA school. I basically followed the nephrologist around for a week. And then the next week he was like, those are your rooms. I'm going to the hospital. And I was by myself. He said, call me if you need me. And then when I went to the primary care spot, it was 6 rooms. And he basically was like, okay, those are your 3 rooms. I'm going to the hospital. I'll be back at 1. Again, that's the era I grew up in. So I had to learn on a curve. So you're talking about a guy who would walk in, see a patient, get all the stuff, run back to my desk, pull out my 5-minute clinic consult, make sure I got everything straight, looking up all my stuff, then go back in the room and tell them, what I think, what we're going to do and stuff. Or I did so many referrals back then, it was ridiculous. So it's one of those things where it's like, yeah, I'm all for a sink or swim if you can do it. But if you can't handle it, then of course let the doc know, and then you can transition to another job. But that's just how it was. Because even my teacher, Dan Chambers, told me his story about how he started practicing. And when he graduated from PA school, and this was before me, he was like in like 80s or 90s. He was like, he literally reported to work and the doc wasn't even there. Like, it's just like, yeah, you're in charge now. So it's just kind of like, that's your moment. So I know nowadays, y'all have options available. Like, there was no residency training for PAs when I graduated. There was no, there was no 3-month pull on and train thing when I came out. Like, literally what the question that you're asking was normal 17 years ago. Like, there was no question. It was whatever job you got, that's where you worked. There was no training. There was no nothing. It was like, yo, this is your room. And especially when they had the fast care, or like the urgent care part of the emergency room. I forgot the name of it. But anyway, the mid-level provider, either nurse practitioner,
Fast Track.
Yeah, Fast Track. So yeah, when I graduated, my home hospital just started having Fast Track. Like, they just started Fast Track when I graduated, and that was in 2003. And yeah, if it was your turn, those were all your rooms, and they had like 8 rooms in the front. Yes, the ER docs were in the back. Don't worry. I mean, it wasn't like you were always by yourself. Like, you could always walk back there and talk to somebody. But yeah, man, it was on your own. So I understand the question, but my era, there was no question. You graduated, you are a PA, you get put to work.
Okay, wow. And how accessible, I should say, was your attending? Were they there when you, like, were you able to text them or call them if you had a question when you started off?
Sometimes. Now, I'm gonna make this statement, and I don't know if I should, but there was a period of time where my supervising physician was available by phone. However, it was an international phone call because he was in Africa. So that's all I'm gonna say. But for the most part, my first job when I was at the community health center, Dr. Khan was in the clinic. Dr. Mustafa was available by phone, but he wasn't really around me a lot. And then when I worked at the primary care clinic in Heat Springs, he was around in the afternoons. But in the morning, if he had procedures and stuff, it'd be hard to reach him initially. So that's about all I'll say.
That could happen, but I mean, that's why you have a team. And, I mean, as a new grad, it may not be the best to start off, of course, like that sink or swim or on your own. Actually, ER is probably even better for new grads because you have doctors there that you can, turn to. And if you do start off in urgent care, at least when you're working with someone else, whether it be another PA or nurse practitioner, you have somebody to feed off of, and just making sure you get that good training too. Yeah. So thank you for that. Before we move on to case studies, I just want to say, I forgot to say in the beginning that Wesley actually does shadowing as well, and he's built a great platform and following. Wesley, can you tell us a bit about your shadowing that you do and how students can also access it?
Okay, so I've been doing virtual shadowing for about 4 months now, I believe. I've been doing it once a week, but I'm gonna have to slow up a little bit. But basically, the way that I was doing it was I was having people log in to a Zoom, and I would just do a Zoom call. And then that got a little bit too big. So what I started to do then was I started to stream on YouTube. So all you have to do is subscribe to my YouTube channel, and then I'll put a date and time for a virtual shadow. You log in at that time, and you go through the virtual shadow. I have some questions at the end. You email me the questions, and I give you a certificate. So that's how I've been doing it for the past 2 weeks. And the reason why I'm doing it like that now is because my Zoom call actually got hacked like 3 or 4 weeks ago, which was a very bad experience. So that's why I decided to just go ahead and switch over to stream on YouTube. That way nobody else would be in the Zoom call except for me. So I don't have to worry about getting hacked again. And then they can submit answers to questions and get a certification. So it'd be a little bit easier. I won't be doing any more this year. I'm taking a break for the holiday, but I will be starting back up first of the year, and I'll be doing them either once a week or once every other week. So yeah, just subscribe to my YouTube channels or follow me on Twitter, Funchess PAC. And I'll be updating when I'll be having the next one, and we'll be starting fresh in January.
Is your YouTube also Funchess PAC?
No, my YouTube is Lily Kate. It's named after my scholarship foundation. My mother's name is Lily Gibson, and my dad's mom's name is Kate Funchess. So I set up a scholarship foundation on behalf of them that just offers scholarships to African Americans who are currently enrolled in PA school. And we had one set up at Francis Marion, but that one got Francis Marion's PA program closed down. So I'm about to set up one at another college, but that's TBD. So I'm not talking about that now. But yeah, it's called Lily Kate. That's the YouTube. I don't have the link.
Lilly. Oh, somebody posted it. Becky, thank you.
Becky is always on it. Is she in here?
Yeah.
She is always on it. So she'll probably post my Twitter handle too, knowing her. So appreciate it, Becky. Thank you again.
Yes, for Becky. Listen, you just have those loyal students that's what we need.
Yeah. She's got my back. Her, appreciate it. Shout out to Becky.
All right, so we're gonna and also I'm gonna be a guest on Wesley's shadowing on his YouTube. Not sure yet. I'll let you guys know very soon. But
appreciate that, man. Thanks for returning.
I'm excited to come on. So thank you, Wesley, for the opportunity. Start off with case studies.
I hope everybody can. If not, please let me know. But for those of you who have all of my virtual shadows in the past, you know that I like themes. I've done one on ear, nose, throat. I've done one on cardiology, respiratory, and I've done 2 on skin. I've done 2 on ear, and I've also done one about urgent care, whether or not, quote unquote, it's time to go. So for those of y'all who have attended my old ones, you know that this is just my thing. I have themes. This is an old virtual shadow that I did a while ago. It was about the integumentary system or the skin. And usually what I do is I talk about whatever whatever organ system or whatever organ I'm talking about. I give a brief overview of it, and then after that, I get into the case study. I'm not going to do that this time. But this is where I'm going to start, because the next slide is the slide that has the case study. Okay, so just a brief thing about the skin. Let me pull up my pointer. I just want to let you know that the skin is broken down into 3 parts: epidermis, dermis, and subcutaneous layer. Hair grows out of the dermis. We also have oil glands, nerve endings, sweat glands. The sweat glands are the ones that travel up this way. This is the sweat gland duct per se. So these are exocrine glands. These are glands that are on the outside of the body, not endocrine glands. Like your pancreas is inside your body. It is an endocrine gland because it's inside, whereas sweat glands are an exocrine gland because they are outside of the body. Just one quick thing. I get into more detail during virtual shadows and stuff, because I really go in depth with these slides. But for now, because I don't want to take too long with this case study, I'm going to go really quickly. I'm going to try to explain everything as best I can. So I hope that we get through this okay. And here we go. This is a patient that I saw a while ago. I won't forget him because he was a very funny guy. He was a 48-year-old male who was being seen as a patient. Now, as y'all know, I have a primary care background.
Do you mind if
primary care background? I always do.
Sorry. Can you hear me?
May not be a complete history, but I do a history on all of my patients. Do I need to do a history on all of my patients in urgent care? I do not. But after spending 10, 11 years in primary care, I have grown accustomed to doing this. It's like second nature to me, and it will actually make me perform better to just go ahead and run through it as opposed to not. So it's always the same stuff. Hi, my name is Wesley. I'm a PA here to see you today. I know that you're here because you're having some issues with your thumb, but for me to better care for you, I need to get an accurate history. Would you mind if I take a history first before we talk about what's going on with your thumb? Most people are okay with it. They say okay. And he was perfectly fine with it. So his complaint was right thumb pain. So because he is a new patient, I always do the history first. So here's the history. His mother had high blood pressure, grandparent had high blood pressure, and also had a heart attack. Social history: he smokes 1/4 of a pack a day. He doesn't drink, no illicit drug use. He is married, and he works as a machine operator. Surgical history: he's had surgery on his left wrist, and he's also had a colostomy. The colostomy was due to a GSW. For those who don't know what GSW is a gunshot wound. So that's why he had to have a colostomy. His allergies is the penicillin, and he is not currently taking any medications. So what happened? Well, he told me that 2 days ago he was moving a pane of glass, and the glass slipped and his thumb, quote unquote, got cut. That's how we said it. I was carrying the glass, and then the glass slipped out of my hand and my thumb got cut. Asked me if he was wearing gloves. I'm sure you know the answer to that question, which is why whenever you move glass, you are to wear gloves. The wound is in the palmar aspect of his right thumb and the metacarpophalangeal joint. Now, that's a whole bunch of big words, right? So why don't we break this down to understand exactly where the cut was? So there are 2 things you need to know about hands and feet, and that's the palmar side, which is your palm of your hand, and then there's the dorsal side, that's the back of the hand. So if he cut his hand on the palmar side, it's on the front. So what we know with saying palmar is that we cut his hand. He cut his hand on the palm, which is the palm side or the front side of his hand. So we got that part. We also know that it's on his right thumb. So this is my right hand. We know he got cut here, and we know he got cut on his thumb. But where did he get cut on his thumb? It says in the metacarpophalangeal joint. So the MP joint is the joint that connects the finger to the hand. If I was to make a fist, every knuckle that you want to connect with somebody's face is your MP joint. So it's every knuckle. These are your MP joints. It connects your finger to your hand. And on your thumb, it's right here. So it connects the thumb to the hand right here at this knuckle. But he got cut on the palmar side. So his cut was on the palmar side, right thumb, right in the joint. So we know exactly where he cut his hand, even though I used all of those big words. Patient tried treating it with a liquid bandage and a butterfly bandage with a Band-Aid, but it kept getting worse. He was advised by his family, which was his wife and his daughter, to be seen. So he's not there because he's in pain. He's there because his wife and his daughter made him come. He has increasing of pain and swelling, but now he's noticing some drainage from the cut. The pain is constant, throbbing pain, and he rates it as a 6 out of 10, and it does not radiate anywhere. When I say radiate, it's not like he has pain in the cut, and he has pain also in his wrist. Radiation means that it's moving from one area to another. His pain does not. It is a throbbing pain. He rates it as a 6 out of 10. Review of systems, ROS. Whenever you see ROS in the chart, it means review of system. He has pain, he has swelling, he has redness, and he has drainage. He has no fever, no chills, no itching, no burning, no stinging, and he is not nauseated. He has no vomiting, no numbness. And I put stinging twice, but whenever you have somebody with a skin injury or skin issue, you always ask about itching, burning, stinging, and pain. That can really help you figure out what's going on. And right now we're dealing with pain, swelling, redness, and some drainage. Okay, physical exam. He's 5'9" tall. He weighs 165 pounds. Temperature is 98.1. His heart rate is 68. Respirations are 16, and his blood pressure is 108/72. Oxygen saturation, which they put the little thing on your finger, 98%. HEENT means head, eyes, ears, nose, and throat. This guy came in for thumb pain. Why did I do a complete exam on him? Because I've spent 10 years in family medicine. Patients get real sensitive if you don't touch them in family medicine. If you walk in and you don't touch a patient and you walk out, they will give you a bad review. They will talk trash about you, and they will not come see you. So when I was in family medicine, Dr. Smoke, the guy that got me the job in nephrology, he said, you always touch your patients in family medicine. They want to feel as though they were seen. And if you don't touch them, they don't feel like they were seen. So for all my patients, I still do it. Will you need to do an exam on people who come into urgent care? No, you won't. You won't. Just look at the thumb. You'll be fine. But I still do it. So HEENT is head, eyes, ears, nose, and throat. It was unremarkable. Chest was clear auscultation. Heart showed regular rate and rhythm. His abdomen was soft and non-tender, and there was no swollen organs. So let's get to the part that we're discussing. Oh, sorry. Musculoskeletal full range of motion in the thumbs. Always check both thumbs so you know what you're dealing with. Whenever you have an injury on one extremity, always check the other one first and compare them. You have to do that. There was neurological. There was no decreased sensation in the right thumb at the distal and proximal phalanx. For those of y'all who want to know what that is, distal is away from the body. Proximal is close to the body. So when you look at a thumb, there are two bones in the thumb. The one that's farthest away from the hand is the distal one. The one that's closest to the hand is the proximal one. Okay. Extremities, there was swelling noted in the right thumb. So integumentary, which is the skin. This is the crux of everything that we're dealing with right now. He has an approximate 2.2 centimeter laceration, which is cut, noted on the palmar aspect of the MP joint. We know where that is now, of the right thumb. Epithelialization was noted along the wound with purulent discharge noted. Purulent is another word for funky smelling, basically yellow-green stuff. So at this point, I would tell the people that are in my virtual shadow, I need y'all to tell me what you think is wrong. And I take a minute and I go over, and then I let y'all answer. And then I wait a minute and then we do an answer. And then I'll tell you what the answer is. I'm not going to do that this time, but I'm going to tell you what was on my.
Oh, you can do that. No, that's what we do. You can do that. No, I want you to do that.
Cellulitis of the right thumb or a puncture wound of the right thumb. I'm not going to wait for answers this time. I'm going to go ahead and I'm going to answer, for the sake of time. And the answer is he has an infected laceration of the right thumb. An infected laceration of the right thumb is an open cut or wound with purulent drainage. So it's basically a cut that's pussy. You got a pussy cut. That's a good way. Well, no, that's actually not a good way to say that. Sorry. When you're dealing with open cuts to the hand, there are specific antibiotics. The last up-to-date that I saw, the top 3 antibiotics that are mainly used in this situation is Augmentin, which is a penicillin type antibiotic with clavulanic acid. It kind of helps for patients who have who has a resistance to regular penicillin. Sometimes Augmentin can help with that. Cephalexin, which is, I believe, a first-generation cephalosporin, if I'm not mistaken. And then also clindamycin, and I forgot the one that clindamycin was, so I apologize. But those are the 3 main antibiotics that are prescribed when you have a person who has an infected laceration anywhere on the body, not just on the thumb. So here are a couple of pictures. I'm gonna get my pointer so y'all can see something. There are 2 ways that you can find out for swelling. So we can look at this thumb and tell that it's swelling. One way that you can tell is by looking at the ridges in a person's thumb. 9 times out of 10, for some reason, genetically, if you put both thumbs together, you will have ridges in both areas of both thumbs. So if you look at this thumb, you'll see a pretty deep ridge here. But if you look over here, you'll see that their ridge is not as deep. And if you look at this hand and look at this thumb in general, look at the knuckle, look at this, you can pretty much tell just by checking that he's got swelling in that. So that's why it's always good to compare. You can also tell that he's got like a pretty manual job by the dirt on his nails. Like, I think he was either at work or leaving work and his wife made him come in. So that's the only reason why he's here. So that's one way that you can spot swelling. Now, he took a picture of his cut before I saw it. Now, as you can see, what are we looking at? Is this the palmar side? Yes, it is. It is the palmar side. Is this the MP joint right here? It sure is. So he has a cut on the palmar aspect of his right thumb in the MP joint, metacarpophalangeal joint. So you'll know exactly where a cut is by accurately explaining where things are. So now that's how it looked 2 days ago. Now this is how it looked when I saw him. As you can see, this white stuff here is epithelialization and granulation of the tissue here. This is the discharge and the drainage on the thumb. And where is it? Palmar aspect, right? And this is the MP joint. So that's exactly where the cut was. Palmar aspect of the joint. There's some epithelialization and granulation tissue being done here, being formed here. And there's the pus and the purulent drainage. So what was the plan? Again, I would take a break at this point and I would say, okay, so we know what's wrong now. How do we treat it? So we would culture the wound, irrigate the wound, close the wound, place on antibiotics to treat the infection and follow closely. Do you culture the wound, irrigate the wound, leave it open, place them on antibiotics and follow up with primary care? Or do you culture the wound, irrigate the wound, partially close the wound, place it on antibiotics, and have them come back in 2 days for complete closure of the wound? The answer to that question is you actually culture the wound, irrigate the wound, and you leave it open. And the reason why you leave it open is because of this graph right here. This graph tells you the process that your body goes through the minute that you cut yourself. So this brown represents minutes, yellow represents hours, green represents days, whatever. So they always tell you that if you have a laceration in your hand, you have 12 to 24 hours. Well, they say 12 to 18 hours in order to suture the wound. And the reason why they tell you that is because of epithelialization. It's hard for me to say that word. I apologize. Basically, I'm sorry, I'm messing up right here. Basically, epithelialization is a process where the epithelial cells are moving upwards to repair the wound. So if you want your wound to repair, do you want the skin far away from each other or do you want the skin connected? And the answer is connected, because then the wound can heal together as opposed to apart. Because 6 hours after you've cut yourself, your body is already producing epithelial cells to help close the wound. And if it gets to the point where you start having granulation tissue, you can pull that skin together all you want to. It is not going to touch. So that's why they tell you that when you suffer laceration, you got 12 to 18 hours to get that laceration closed up, because once epithelialization gets real bad, well, not real bad, but it's improving the wound and granulation tissue starts to form. As you can see, this is the 12 to 24 hour mark right here. Once this starts happening, that wound is not going to close fully, going to close completely. It's going to have to heal itself. Now, eventually it will, but you'll have a bigger scar that way. So that's the reason why they always tell you to come in, because this is the process. From minute one, the minute you cut yourself, your blood vessels constrict. That's just what they do. Coagulation happens, your blood starts to clot off because they've got to stop the bleeding. Your body is also working to stop the bleeding. You're holding pressure there, and the blood vessels are constricting, and the blood is clotting. After that, the blood vessels dilate. Well, why are the blood vessels dilating if they're trying to stop the bleeding? Well, they have to dilate in order for these cells and the white blood cells, neutrophils, and all that stuff to get to the wound, because they got to clean up the wound. So the blood vessels have to dilate in order for that to happen. And of course, there is an inflammatory process that starts about 30 minutes after you've cut yourself. Okay, so this is the process for a wound to close. And honestly, in order for a wound to close completely, it'll take 1 to 2 years. I know after a week the stitches are removed, but that's only because the granulation tissue is formed, epithelialization has happened, so the wound is closed. But in order to get the skin the way that it was before you cut it, it's going to take 1 to 2 years. You're only 50% of normal strength on that cut after 2 months. So it takes a while for wounds to heal completely. But once you reach the maturation and remodeling phase, about a year or two, man, you'll be absolutely fine. So that's the reason why I left it open. He came in 2 days late. By then, the granulation tissue and epithelialization already happened. Plus, it's infected. You never close an infected wound. So we just had to leave it open. And we told him, look, you're going to have a scar. It's going to look kind of bad, but I'm going to treat the infection. I'm going to decrease that swelling. You'll have better movement of your thumb, and you can go back to work, because apparently that was more important than coming to urgent care to take care of that cut on your hand that got infected. So the reason why the other ones weren't correct is because, did he have a laceration of his thumb? Yes, he did. But it was also infected, so you can't just leave out part of it. Did he have cellulitis in his thumb? Yes, he did. But he also had a laceration of his thumb. So he had an infected laceration of his thumb. And I guess I could have put with cellulitis, but I didn't put that part on there. But I just called it an infected laceration. And the reason why it's not a puncture wound is because the mechanism of injury. He didn't stab himself with anything. He was carrying a plane of glass without gloves, and the glass slipped and cut his finger. So, any questions? I hope I didn't go too fast, man. I normally, you can ask most of the people that come to my virtual shadows. I really take time to explain stuff a little bit better, but for the sake of time, I just wanted to go ahead and just go through one case study at this time. So that's my spiel. I'm done.
That was really great and very informative. I'm not sure if anybody has any. Okay, so we have some questions. How is staff coverage with Doxy in your part of the world?
Yeah, we're still good. We have very little resistance to staph here. Because I sent that wound culture off, and it was staph. It was a staph infection, but it was a pretty punk one. It was sensitive to all antibiotics. But yeah, doxycycline is still very functional here. We haven't had too much resistance here.
Okay, good. And so, excuse me. One question somebody had that I thought was interesting was about the penicillin allergy and antibiotics to prescribe. I know that I feel like that as far as the allergy, it seems to have, like, based on other providers I've spoken to or spoken with, they kind of determine on the severity of the allergy, of course, on whether or not to give certain antibiotics, like beta-lactams or other penicillins. So I know, like, if it's, of course, anaphylactic, you wouldn't do any of that. But if it's like a rash or something minor, they would still give Keflex or something. I mean, I sometimes wouldn't even do like Augmentin or anything like that. I wouldn't even try Keflex. But how do you feel about like penicillin allergies? And then a lot of times they're not even allergic to penicillin really. It's more of an adverse reaction than an actual allergy.
Yes, there's a difference between allergy and side effect. So a lot of times patients have side effects to medications and they're not necessarily allergic to medications. And it takes a lot of teaching to explain to them the difference. I mean, and granted, most patients won't care, but yeah. I personally, because so far the numbers that I've seen is 10% of patients who are allergic to penicillin are allergic to cephalosporin. So then it's like, you can either look at it as though there's a 10% chance that you will have a reaction, or there's a 90% chance that you won't have a reaction. It all depends on how you look at it. So I always tell patients, look, it's a 10% penicillin to cephalosporin reaction, but there's a 90% chance that nothing will happen. So, I mean, I have no problems prescribing Keflex for patients with penicillin allergy. I do it more often than I don't.
Right.
So, and as far as allergy versus side effect, if a patient develops a rash or swelling, I don't prescribe the penicillin. But if they have like diarrhea, or if they have nausea or like stomach upset, I'll let them know. All right, well, diarrhea maybe not, but just like a little stomach upset or something like that, I'll tell them like, look, in this case, this is probably the best antibiotic for you, but I know that it causes stomach issue. I can prescribe something else to take with it so you don't have any issue, just so you can take this medicine so it can help you feel better. But that happens rarely, because 9 times out of 10, there are so many other antibiotics that are available that you can prescribe until it's not really, you don't necessarily have to go with penicillin. It's just one of those things where it's like, if I have patients that are, because you got the patient, they're allergic to penicillin, sulfa, and levaquin. So it's just kind of like, okay, now we got to break down what's allergy and what's side effect.
Yeah, I hate that.
I mean, and granted, you can always switch over to a macrolide or doxy or something like that. But for the most part, once you start breaking it down, you know that they aren't allergic to those medications. They're having side effects on them. And if we can take care of the side effects, they're actually okay with taking the medication.
Right. Thank you for that. I think there were like a few more questions. Somebody said, have you ever seen anyone cut their median recurrent nerve in the thumb?
Never. I have never seen it. I did have a couple of cases where patients have cut their nerve in their middle finger when they were slicing something. And in those cases, those have to be fixed by a neurosurgeon. They just do. And then I've had some tendon cuts as well. Those have to be fixed by a hand surgeon. So in those situations, though, you can basically tell whether or not it's nerve or muscle. Basically, that's what the purpose of the full range of motion in all joints. If he couldn't bend his thumb, I know that he's either got a tendon or a neurological issue, in which case I give him the antibiotics and I send him straight to the ER so they can consult a hand surgeon at that time, because the sooner we can fix this tendon, the sooner we can fix this, it'll be easier. So there have been a couple of cases where I've had a couple of providers who they had a cut here on their finger, they stitched it up, and then they couldn't bend it. Like they were doing this when they came to have the stitches removed. And that's when you hit the old crap. And it's like, hey, this is not as easy as you think. I think you cut a tendon in your finger. You're going to have to see an orthopedist. And then comes the why they didn't tell me, and then some other stuff. But you always do the physical exam to check on it. And I've only had one case where a patient cut a nerve. But most of the time it's basically tendons is the most common one.
Right. Yeah. And I always say this, to be careful with the hands, because that could become a lawsuit, because people need their hands. So, if you notice something that looks weird or funky and you don't know what to do, it's best to refer them to the ER, get a hand surgeon involved, especially if they can't do that range of motion, or you feel like they, hit a nerve, or of course an artery or anything like, like that, where it's an outpatient, refer them to the ER. You do not want them to not have or regain full functionality of that hand because of you or because of something you missed.
Exactly. That is exactly right.
Okay. So it's 8:00. I know it's the end, but this was so informative. Thank you so much, Wesley. Becky actually attached your YouTube and your Twitter again, you guys. His YouTube and Twitter is in the link. Once again, he does also do shadowing. So make sure to follow him on YouTube and Twitter to get more information on when he does his shadowing sessions. And I'll be a guest on his shadowing with the emergency medicine aspect of things. And thank you once again, Wesley. This was great. Thank you. Thank you. I hope we can have you later in the future.
Yeah. Just let me know, man. I have no problems. Because honestly, I've done like 18 of these. So I got so many case studies. It doesn't matter.
That's awesome. Yeah, and I like that you had a picture. I like the fact that you had a picture too. So they actually saw what you were talking about.
Exactly. I got quite a few.
Yeah, and so there's videos on your YouTube of past eShadowing.
Okay, so real quick, on my actual YouTube channel, there's only 2 videos that are shown. The 2 videos that are shown is when I interviewed Alan Platt, the admissions director for Emory University, and also when I did a urgent care. I just talked about what I did in urgent care. It's called It's Time to Go, trying to figure out when do we treat a patient versus sending them to the emergency room. Those 2 are directly on the channel. If you subscribe to my channel and click on the discussions tab and sort it, you'll see a list of all of my other virtual shadows.
Okay, gotcha. Actually, Adam is, thank you for that. But Adam, he connected me with Adam. Thank you again. And Adam is part of the admissions team at Emory. So if anybody is especially interested in getting into Emory or just PA school in general, which is everybody, he's going to be our guest for the 4th, for January 4th. So we'll learn more about the admissions process. And of course, you can start to see a little insight on that by going on to Wesley's YouTube. So guys, I'm really excited for that because I didn't even have that when I was applying to PA school. So thank you, Wesley.
No problem. I know it's after 8, so I know y'all got to go. So all right, subscribe to the channel, YouTube, Twitter, and I'll let y'all know we'll be starting again in the new year.